Hello, my name is Leon Eydelman. I'm a emergency medicine and critical care physician at Advocate Good Shepherd up north in Barrington, as well as out here at Advocate Christ. So thank you all for coming to our symposium. We're so happy to have someone to talk to. We're used to just talking to ourselves. So this is quite the treat. I'll be talking about ECMO today. It will be a very abridged, a very abridged survey, let's say, of ECMO for lung failure in particular, okay? I have no disclosures, no financial disclosures. I will say I worked overnight, and my boss is making me work again tonight. So I have that to disclose, but otherwise nothing else. Okay. So ECMO explained. ECMO stands for extracorporeal membrane or extracorporeal membranous oxygenation, and it really is as simple as it sounds. So the concept is simply that the function of the lungs, oxygenation, and a little bit of ventilation too, that's important, occurring outside of the body. This is not a foreign concept to human beings or really any mammals. It's actually rather natural. We'll get into that in a bit, but that is what ECMO is. Extracorporeal membrane oxygenation, typically with this abbreviation. So, pardon me? Oh, thank you. All right, excellent. So this is one brand of a particular ECMO circuit, okay, just as a view. This is one ECMO device. That's a bedside table for scale that we all know and love. So ECMO started from, let's not say humble beginnings, but it started as cardiac bypass, right? Our cardiovascular surgery colleagues need a still and bloodless field. That's very important. We all know that. Still and bloodless, right? So that's difficult to do when we're talking about a patient's heart, because if a patient's heart becomes still and bloodless, they're unlikely to do very well. So our anesthesia colleagues figured out a way to allow this to happen by developing bypass circuits. Cardiac bypass is kind of the birth of ECMO. And initially, you know, you can tell because it's black and white, it's an old thing. It's one of the first bypass devices, okay? And from this, we got much better at anesthesia, cardiac anesthesia. We had much better machines. And then someone had the bright idea to start moving them to bedside. So it's a pretty big device. I don't think that would fit in any of our rooms, but this is a, let's say, kind of first generation. You saw the first picture of an ECMO circuit. That picture has everything this thing does, minus, of course, the sharps container. But everything else that we see there was featured in that other much smaller ECMO circuit, okay? So as we progress and get even better at this, we really start to see some I think, amazing things we can do with this technology. This is a museum in France. It's called the Louvre. It's where the Mona Lisa is and many, many visitors, right? And this is a patient who, unfortunately, suffered cardiac arrest right there while gazing at all that beautiful art. And in France, they have a different system than we do. They have the resources, they have the abilities to deploy folks who can actually cannulate for ECMO anywhere. And so this is a picture of someone underneath all that art getting cannulated for life-saving extracorporeal support, okay, right there in the middle of the Louvre. So just something that could be. We don't have this here in the United States, but we are making progress. So you can see the amount of ECMO is taken off dramatically. This is both the amount of centers and the amount of cases each center does. A lot of reasons for that. The mid-early 2000s, we figured out how to make those enormous machines much smaller. We gained a lot of experience from our various wars overseas, and we had a lot of really bad flu epidemics that were laying low young, healthy people that otherwise would have done just fine if we could only get their lungs to rest for a bit. So that's ECMO. Now, there's a lot of things to say about ECMO. There's a lot of things we can do with it. We're going to take just a small bite here and discuss veno-venous ECMO for respiratory failure, okay? When I say veno-venous, I say that as opposed to veno-arterial. And those two words, veno-venous, veno-arterial, describe the cannulation strategies. We'll get to that very briefly here in a minute, but just as a little picture here. So this is a patient on ECMO. They're very, I'm sure our ECMO patients are. We see that our patient has a somewhat large cannula in the IVC from which blood is being drained thanks to the help of our pump. That blood then moves up into our fake lung where we get gas exchange occur exactly the way we want it. And then the pump drops this blood, or I guess with the aid of gravity, right back into our venous circulation, into our superior vena cava. This is one method of VV ECMO, but all VV ECMO is going to have a cannula in the venous, a cannula in the venous system, and blood will go back into the venous system from the venous system. So that means there's one very important thing an ECMO patient needs to have, and it's got to be working pretty well, and that is a heart, right? So for heart failure, for cardiac arrest, for things like that, we cannot use veno-venous ECMO, okay? Veno-venous ECMO is a particular rescue therapy for lung problems, such as ours, as Dr. Jonas was speaking about, and something about Dr. McHale's too. We'll co-opt all these talks. Okay, so that's what ECMO is. That's what ECMO is. So the concept is very simple. Obviously, the devil is in the details. The execution is not often quite so simple, but it can be. And I really encourage all of us to think about this like a simple thing that is very feasible and doable, okay? So why would we want to put someone on ECMO besides that we're into it and we like it? Why are we doing this? These are some pretty, I'd say, universally discussed indications. Okay, so obviously to begin with, if we can't get our oxygen or our carbon dioxide to where we need it, and we're at the end of our mechanical ventilation strategy, we've got nitric oxide on board, we're prone, we're paralyzed, we've done steroids, we've done voodoo, we've prayed to every deity, we've done everything we can, but our oxygen is too low, our carbon dioxide is too high, and our patient is going to die if that doesn't change. Well, great. Time for ECMO, right? Because with extracorporeal support, if done right, if done successfully, without a doubt, we can get proper gas exchange. We can get proper gas exchange. Whether that solves the patient's problems, another story. But we can get proper gas exchange regardless of the difficulties of the pulmonary problems with veno-venous ECMO. So that is I think, gimme indication. If you ever find yourselves in your various places and careers and spots in the hospital with a patient who is not achieving adequate oxygenation or ventilation, despite everyone's best efforts, I urge you all to please consider calling whomever or doing whatever you can to get ECMO involved for this patient, okay? That's the main indication. Sometimes we get the numbers we want. We get the oxygen barely there, we get the carbon dioxide sort of there, but it's not feasible, right? Our patient's respiratory rate is 60, and they're breath stacking. The breaths keep building up in the ventilator. And that is an unfortunate consequence of positive pressure ventilation, which is all we have. No more iron lungs, right? So this is what happens with positive pressure ventilation. Or perhaps you're achieving the numbers you want, but your plateau is that scary 40 that Dr. Jones was talking about. So again, I would say these are indications for considering extracorporeal support for this patient. These are indications, not just we don't get the numbers we need, but what we're doing to get them is inappropriate, or we know that it could cause harm, okay? Hemodynamic instability is also a potential indication. I should have put a big asterisk there, though. Hemodynamic instability because of mechanical ventilation, okay? If you're hemodynamically unstable because you were hit by a car, VV ECMO will not help that. That I'll say, that I'll admit. It will not help that, okay? But perhaps your patient with a plateau of 40 and a respiratory rate of 40, for whatever reason, with all that enormous amount of pressure in their chest, their heart's not working the way it should, or they're not getting the volume returned into their right side of their heart the way that they should. Well, if that's the situation, then we need an alternate strategy besides mechanical ventilation. And extracorporeal support is that strategy. So if we're in these positions, I encourage us all to think about getting ECMO involved with our patient. And this is very intensive care unit kind of indications and thoughts, okay? Now, this next set of indications is a little more emergency medicine, okay? It's a little more outside the box. And I want to bring these up because I want us all to think about our patients for whatever reason that might be helped by VV ECMO, okay? And these are a few patients that might be helped. And these patients potentially need this a little faster than kind of some of our ICU rounds where we've got a few hours, talk about potassium replacement, things like that, right? These might be patients that are presenting to an emergency department, and the emergency department folks should know that we got a great answer for this, and it's called ECMO. So much less data about these things, I'll admit to y'all. And the data about the previous indications, let's say, is not, stellar. Still some controversy there. But Dr. McHale gave an excellent lecture about our patients with horrific endobronchial lesions, horrific pulmonary hemorrhage. If anyone's been involved in those cases, they're terrible from every respect. Obviously, from a patient perspective, it's a horrible thing that's happening. Those of us bronching don't appreciate bronching for 2 or 3 hours, typically, unlike perhaps Dr. McHale. I'm not as good as he is, and so, it gets very difficult. It really ruins your day, okay? But the thing to keep in mind, again, as Dr. McHale said, the thing to keep in mind is it's not the exsanguination that's going to kill your patient who's suffering from pulmonary hemorrhage. It's the fact that the blood is ending up in the lungs. Or really, it's the fact that we're still using those lungs for gas exchange. Because if we're not, well, then we can wait till that hemoglobin drops to 4 before our patient arrests, right? So it's very possible that in the 1, 2, 3 hours that our patients are being bronched, that we're getting a little progress and then not, and then a 2 steps forward and 1 step back situation. In all that time, this patient could have been on VV ECMO by then. And then we could all say, oh, great, let's go see that patient, who rolled their ankle in the hallway. Because now we have time. We can stop doing this. We can wait for our colleagues to come in and do a more, formal and more thorough bronchoscopy, because our patient does not need those lungs for gas exchange. Okay, so keep this in mind as a potential. Dangerous intubation, emergency medicine, that's a big deal. We don't want to mess up a bad airway, and we want to know who is at risk for a dangerous intubation. Folks who have no neck, for example, folks who can't move their neck. There's a lot of things where someone walks in, you go, oh boy, this is going to be a problem, right? And these sorts of patients exist whose risk of intubation, perhaps with a, again, central obstructive lesion, where we're worried if we paralyze them, they'll have complete airway collapse. These patients exist for whom the risk of ECMO can be significantly less than the risk of intubation. And if you've met such a patient, then I urge you to consider ECMO for him or her, because without a doubt, we would rather have a controlled VV ECMO cannulation, which can be done typically well, typically without issues. And now we don't need to worry about this dangerous intubation. They don't even have to go to sleep for the ECMO cannulation, potentially, if they're very calm people. But they can have a little twilight, a little procedural sedation. It really changes. It gives us another tool where we don't have to, hope that someone comes in to help us intubate this patient, okay? Temperature control is another big one. So I trained, my emergency medicine training was in Las Vegas. And every single year, there's a lot of festivals and concerts there, but every single year, there's a big rave electronica festival, and it's right in the middle of the summer. And every single summer, 5 or 6 a.m., EMS would scoop up a bunch of 20-year-old kids with temperatures of 108 degrees, seizing like crazy. And we were all, we knew we had to be not hungover that day. We had to be on our A game, because we knew that these folks were coming in and it was going to be a big deal. I mean, we had like water everywhere, fans everywhere. So towards the end of our algorithms for temperature control, we have things like this. Okay, dialysis is classically brought up as, hey, if you really need to cool or heat someone, put them on dialysis, have them run dialysis through a heated bath of some sort. We can get several degrees an hour, 1 degree an hour temperature change just with that. ECMO has rates of anywhere roughly 10 times. Our blood flow rates are 10 times roughly on an ECMO circuit, at least they can be, as on a dialysis circuit, which means 10 times more exposure of that blood to heating or cooling. And this can make the difference between life or death in a patient who is dying of severe temperature abnormality. Okay, so these are more emergency medicine indications, and I encourage those of us who work in the emergency room to always consider this as a potential option for how we have to get through the problems that our patients present us. Okay, keep this in mind, potentially. Okay, so how it works. How does ECMO work? Well, it's really simple. We've all done it. We've all had ECMO. We've all had ECMO. I promise you, every single one of us in this room has had extracorporeal membrane oxygenation, right? We didn't even need to call cardiovascular surgery for this. All of us have had it. This isn't unnatural. This is how mammals do things. Mammals do this, and then mammals breathe with negative pressure. You'll note that positive pressure is nowhere in the algorithm here. Humans, mammals, living things don't breathe the way that we force them to breathe when they come to our ICUs. Okay, so it's very natural. Briefly, this is kind of a general circuit. We start with a patient, okay? Into this patient, we place 2 somewhat large cannulae. We connect these to a circuit. Now, the circuit has a pump. That's the pump that runs the show, right? And that pump forces blood through the circuitry into our oxygenator membrane. And in that membrane, carbon dioxide goes out, oxygen goes in, and this sweep gas refreshes the whole thing. So it's always ready with lots of oxygen and no carbon dioxide, so it can pick all that carbon dioxide up, okay? On top of this, typically, we love numbers in the ICU, swans, all that. Doesn't matter if it helps, we still love it. We get lots of numbers with ECMO, or we can at least. We can check pressures at all points. And that can give us some information perhaps about some processes. But this, in addition to your ECMO circuitry, you're going to get some information that might be of benefit to you. And this just illustrates as well that blood is actually negatively pressurized here, but positively pressurized after the pump. The reason I bring this up is if you find yourself in a room with an ECMO patient, please don't let air in to the negative side of the blood, okay? If we're going to open things up and let air in, let's do it in the positive side where we'll have blood come out at us, not into the negative side, the pre-pump side. That would not be good. ECMO. Again, one particular brand of ECMO. That's it. I mentioned cannulation. So we do got to get those cannula in, right? No doubt about it. They got to come in. We can't just lay them on top of the patient. It just won't work. So these aren't small. We talked about chest tubes, how we don't want to put 32 French in anymore, 28 French in. 28 French, we're starting to get to the size of some of the bigger venous cannula, okay? And we're not putting them in a chest. We really have to put them into a vein. So it presents some challenges. It presents some challenges. Thankfully, critical care and cardiology and many of the other percutaneous procedural specialties have gotten very good at putting large things into veins and arteries. And so this is a skill we're going to have to keep working on because we're going to need it for this. So oftentimes these patients historically go to the operating room, cardiovascular surgery, cannulates, perhaps open, perhaps percutaneously, but then they come back, right? Oftentimes, or another strategy could be in cath lab. We see a cardiologist here using fluoroscopy. Some of us in the intensive care unit who don't know how to use fluoroscopy simply have to use ultrasound. And that works, or can work, just fine, right? It's just a central line. It's a big one. It takes like 6 dilators, but it's just a central line. And if we're meticulous at our central line placement every time, then we can do this as successfully as anybody else. I mean all of us here, okay? So don't be too scared of these cannula. We don't need to go to fluoroscopy necessarily. So a few advantages of ECMO. A few particular advantages of ECMO. So as we mentioned, the normalization of those gases, right? This is the big ticket item. This is why this exists. Because we're getting the oxygen we want and the carbon dioxide where we want it, right? Perfect. Lung rest, controversial. Controversial. We talked about driving pressure. We talked about how overdistending the lungs is a problem. We don't know what overdistending is necessarily. We don't know how much is too much. We don't know if none is best. We don't know what the best strategy is to work our lungs. When we're on mechanical ventilation, we don't get to make those discussions, we don't make those choices. We have to do whatever we can to get the gas exchange to work properly. On ECMO, not so. Potentially, we could have a patient on PEEP 0, 0 respiratory rate, and that's it. And they're just sitting there. And it will not impact, at least, their gas exchange. I'm not suggesting that. I don't think that's a good idea. But certainly we can deliver much less pressure, much smaller volume, much less drive pressure to our patient's sick lungs if we don't need any of that stuff for gas exchange. So it does give us a lot of, I think, exciting things that we can do from that perspective. We mentioned the sometimes exceptionally high thoracic pressures that mechanical ventilation generates. Again, ECMO allows us to discontinue all those things immediately. This might be more of a lung transplant thing. It might be a little scary, but people walk around on ECMO. People get extubated on ECMO. People waiting for lung transplants walk around. They make viral videos that go on Facebook, right? They live their lives in one small form or another in the hospital. But this can be done. This can be done. You can take the tube out. These patients exist. And now think of the length of stay we've decreased. I mean, bed sores, anything you think of, the ideal thing in the ICU would be to get them extubated one way or the other. And this is one means of doing that. ECMO is not for everybody. That's true. ECMO is not for everybody. And we don't know who exactly it is or is not for, okay? I think a lot of this depends on your own excitement about ECMO. And now a few things to keep in mind. Folks who are, very elderly, have a limited lifespan for one reason or another, be it metastatic cancer or something else like that, you might want to consider if the use of resources and the risk of procedures is really in the best interest of your patient. But I will say this. This patient, who's rather elderly, seems to make it through every single thing that happens to him and is still alive and kicking and doing well. And so I only bring this up to say, let's not discount some of our patients who may have one or another reason that makes it easy for us to say, no, I don't want to put big cannula in someone. I don't want to do that because I'm not very comfortable with doing that. But, our patients sometimes can do much better than we think, much better than we think, even without, blood transfusions, whatever else Mr. Burns needs. And as we know, those of our patients that, are closest to evil do the best. So that might be the best patient. So very, very brief, and I know we don't have any patients like that. Very briefly, the main ideas for this talk, very briefly, ECMO can fill in for failing lungs. It can deliver in some patients, in some categories, significant advantages, but it is not appropriate for everyone. Who that everyone is, we're not sure yet, but it is not appropriate for everyone. Thank you very much.